Let me move on to the third presentation in this session. And let me start by sharing the screen. So it's always a tough act trying to follow Connor onto the speaker podium, even when he's not posing challenging questions to set the scene. Some of you know me. I've spent most of my professional life looking after people with developmental disorders who have got into some sort of trouble with the law. Most of these people have had a diagnosis of some of these people have had a diagnosis of autism made in adulthood, a diagnosis which was not made when they were children or adolescents. And as a group, this is a group that often stimulates in the professionals, whether they be within the penal system or in healthcare, a certain feeling of helplessness. A feeling of helplessness that is not just driven by the oddity of clinical presentations, but also a nagging feeling that nothing you do is ever going to make any difference because of what you perceive as a failure of therapeutic engagement. So my presentation is an exploration of some of the themes in this area, specifically focusing on comorbidities and assessments. Let me start off with a blanket statement. People with autistic spectrum disorders are only ever as likely or arguably less likely than the general population to indulge in law-breaking behavior. And yet, when they do, it stimulates a considerable degree of public and policymaker angst, as evidenced by some of the stories recently in the news. That some of you may recognize him as John D. Bravery, a 17-year-old who was convicted recently for throwing a child off the Tate Gallery in London. That is Adam Lanza, convicted as involved as a 20-year-old in shooting dead 20 grade 1ers, 5-year-olds, 6-year-olds, 6 members of staff, and his own mother in a primary school in the United States, the Sandy Hook massacre. That is Milagro Cunningham, convicted as a 17-year-old for the abduction, rape, and attempted murder of an 8-year-old girl, and sentenced as a 17-year-old to 70 years in prison. And that is Nick Riley, the so-called Exeter bomber, who came under the influence of Al-Qaeda elements, strapped a nail bomb onto himself, set it off in a calf, injured only himself, attracted a long prison sentence, and died by suicide in the first few months of that prison stay. And at the less severe end of that spectrum, that is Gary McKinnon, the Scottish computer and systems analyst, convicted for hacking into the Pentagon as part of his special interest on missing UFOs and the subject of an extradition battle with the United States. What unites all these people is a diagnosis of an autistic spectrum disorder. And yet they are different, not just in the poignant detail of their personal stories, but also the extent of psychopathology and comorbid conditions that were the focus of their treatment, either before or after the event. And that comorbidity extends from personality disorders at one end to a range of mental illnesses, depression, anxiety, and psychosis being the most prominent, and a cluster of other conditions, including eating disorders, which were mentioned as a confounding variable in Adam Lanza's case. In saying all that, I want to highlight those two messages. Quite often, it is not the autism spectrum disorder itself which is contributing to the association with violence, but this coexistence of comorbid conditions and the interface with political policy. In the case of the United States, the availability of firearms. And so I end that introduction by reminding ourselves that lawbreaking in community samples is similar or less for this group. This is what I will cover. I'll talk briefly about the arbitrariness of the forensic label, examine comorbidities, and then have an overview of the diagnosis and assessment process. And Sam Tromans in the next section will be presenting a review of treatment strategies. So arbitrariness of the forensic label. That is a hyper-simplified version of what the criminal justice process would look like from the commissioning of an offense to conviction and if it warrants a prison sentence. When someone with a developmental disorder gets involved in that process, it is entirely possible that they can be diverted entirely from the criminal justice system at any of those points. And that diversion depends not just on the seriousness of the offense they have committed, but also on a range of other factors. Because for people with developmental disorders, the dividing line between offending behavior and what is described as challenging behavior can be particularly thin. Even more so if we are talking about someone with a mild degree of developmental disability. And this contributes to the arbitrariness of who becomes forensic. This also contributes to the arbitrariness of even if you end up in a forensic setting with a comparably serious offense, you can either be on a restricted so-called criminal section, or you could be detained and treated under a civil section, with the boundaries being blurred between the two. And that has implications in terms of planning for services and in terms of professional manpower. Let me touch briefly on prevalence. The first point we have already made, but if you are dealing with selected forensic settings, there appears to be a higher than expected rates of people within the spectrum. And there are a range of studies that other people will describe, from high secure to medium secure settings. And also to make the point that although we say forensic settings, the vast majority of people with forensic problems are actually looked after by community mental health or community learning disability teams. It's only the small minority that ends up in hospital settings. So in all those populations with selected forensic issues, there is a slightly higher than expected rate of people within the spectrum. And most specifically, in a topic that Verity Chester will address later this afternoon, there seems to be an overrepresentation in females within that setting. And part of what contributes to that is a traditional misdiagnosis and mislabeling of autistic spectrum conditions as personality disorders, particularly of the emotionally unstable kind. The summary of that slide is to say that no one particular pattern of offense is associated with autism spectrum conditions. So depending on the sample and depending on the study, people have reported that those offenses are higher or lower. And it is a bit difficult to draw definite conclusions there. Let me now go on to the issue of comorbidities, which I touched on before. And I see this as two phases: one, comorbid developmental disorder conditions, and comorbid other mental disorders. Most of you who go through training programs would know those definitions. So the core features of an autism spectrum disorder, the triad of impaired social interaction, communication difficulties, and restricted and repetitive circumscribed interests, so-called special interests. And this has a wide spectrum with clinical subtlety in the way individual clinicians interpret those things. And the spectrum is wide enough in different classificatory systems. So for example, you could have someone with the first two of those categories, the impaired reciprocal social interaction and communication abnormalities, but without the restricted, repetitive, circumscribed interest. And some people would see that less as autism and more as a communication disorder of the semantic pragmatic type. But the key point is, if you get those three broad areas, you are talking about people at various ends of the spectrum. And I'm going to show you now a series of slides that that have been inspired by, or in some cases straight borrowed from Tom Burney. Tom Burney of Newcastle is one of the two most inspirational teachers I have had in this field, the other being Sam Paunik. And Tom draws a powerful parallel of the night sky to describe the comorbidity of developmental disorders. And he asks you to visualize the Orion and the three brightest stars at the center of the Orion, and conceptualize them as the three features of the autistic triad. And if that is an autistic spectrum disorder, that doesn't occur in isolation on the northern sky. It occurs in close proximity and relationship with a variety of other developmental conditions. Close proximity and relationship being the key description. Some of those other developmental conditions then cluster together as developmental disorders of their own. So overactivity, impulsivity, and attention deficit clusters is ADHD, and obsessive compulsive features in multiple tics cluster as Tourette's. And because they are in close proximity, they can often be comorbid conditions existing independently in the same person. More typically, they become what Tom described as hybrid disorders, the coexistence of both ASD and ADHD features, just a little bit atypical in terms of ASD and a little bit atypical in terms of ADHD, not perhaps satisfying the research criteria for either, but being a significant clinical issue nevertheless. And that is the reality of our clinical practice. And in my practice, I have found this parallel incredibly powerful because it helps as a useful explanatory model when you are talking to parents or loved ones who express their bewilderment about the number of different diagnoses that different clinicians have stuck on their child or their relative. And this helps you to explain how those things may not necessarily be mutually exclusive. So if that is the explanation of developmental disorder comorbidity, you have what Thomas described as a pathology porridge. But the third component of that porridge is also comorbid mental disorders, illnesses, and personality difficulties. And I'll start with psychosis in schizophrenia, and our thinking on that has varied from ASD as a precursor to schizophrenia to the current understanding that there is a genetic overlap between developmental conditions and psychosis. For the practicing clinician, there is a risk of overdiagnosing or underdiagnosing psychosis in ASD, particularly in forensic settings. And I highlight there the 5 pillars of a psychosis diagnosis. And if we start with hallucinations, you can mislabel obsessional thoughts as hallucinations. You can mislabel the internal dialogue in someone with ASD as hallucinations, or the fleeting mental imagery as hallucinations. If you think of delusions, ideas that you may consider particularly unusual or bizarre, imaginary friends, the preoccupation with control, and this proneness to catastrophic reactions when stressed can all be put down, mistakenly sometimes, to delusional thinking. And if you think of the oddities of speech and concrete thinking, that can be misinterpreted as formal thought disorder. The stereotypies and catatonic features of autism misinterpreted as a disorganized motor behavior of schizophrenia. And the social isolation, which is often comforting for people with ASD, for some people with ASD, is misinterpreted as negative symptoms. So if you are a clinician working in a community setting, number of people with autism spectrum condition that you see is fairly limited. It is more likely to be a misdiagnosis of psychosis than the other way around. But if you are in a forensic setting, there is a danger of diagnostic overshadowing and underdiagnosis of psychosis when everything is attributed to the unusual belief systems common in autistic spectrum conditions. And those of you who want a non-psychiatry read on that can go to Google and type in about the accounts of Peter Lancer, who is Lancer Jr.'s father, the subject of the Sandy Hook massacre, who firmly believes that his son's condition was not just Asperger's, but a coexisting psychotic disorder. So that is about psychosis. If you then look at affective disorders, depression is probably the commonest mental illness comorbidity, along with bipolar disorders, and then anxiety. And anxiety is quite crucial because you see it partly as a core feature of an autism spectrum condition, and some people conceptualize it as an additional mental illness pathology. And within the anxiety spectrum, you think of generalized anxiety, panic disorder, and obsessive compulsive features. And in many people who end up in forensic settings, teasing out whether it is a core feature or an additional pathology may often be less important than addressing it if it is present. And finally, particularly for those at the forensic end of the spectrum, it is useful to be quite aware of the sense of hopelessness and the negative cognitive triad, which is often associated with a significant suicide risk. And finally, onto personality disorders. And Connor has touched a bit on this. And I'm, again, saying this from the perspective of someone who's drawing conclusions from my clinical practice of a few years. Quite often, if you're seeing people with autism and an intellectual disadvantage, I have found the cluster A and cluster C personality disorders to be of limited clinical utility when you're planning treatment. While cluster B, the so-called flamboyant cluster, in particular the antisocial and the emotionally unstable personalities, are of particular relevance. I want to show you a couple of slides, initially for emotionally unstable personality and then for antisocial. So up there on the right and left-hand sides are the requirements, or whether you follow DSM or ICD. Those are features of a borderline, emotionally unstable borderline personality. And those, the right and the left features, can very well coexist in both autism and emotionally unstable personality. And often you find it difficult to distinguish. Clinically, the one feature that many people have reported as useful is this intense, unstable relationships which alternate between idealization and devaluation. You know, the phenomenon of describing you as the only doctor who ever understood me 1 week and being utterly useless the next week. That alternation is typically seen more in personality difficulties of the emotionally unstable kind, rather than a more stable picture that you see in autistic spectrum. And when it comes to antisocial, my attempt at a Venn diagram, so about 1/5 of people with an antisocial personality also have what is described as a psychopathic disorder. And there is a small overlap, a small but significant overlap with autism spectrum disorders. And that overlap between autism and that core psychopathy is the so-called double hit hypothesis, which S.E. Whiting and others will be talking about in the afternoon. And I'm trying to explain it with one slide. What is the difference between autism on one hand and psychopathy, which is Hare's concept of psychopathy, on the other? It's a slightly oversimplified chart, but if you think about empathy as being at the core of it, typically the empathy deficit in autism is a cognitive empathy, which is related to the theory of mind. So typically, he just doesn't get it why you are distressed by the actions. But emotional empathy is often preserved in autism. At the very least, they mirror your emotions. So the autistic person who gets quite upset when they see people around them upset. So the deficit is cognitive empathy, while typically in psychopathy, it is the other way around. There's nothing wrong with the cognitive empathy, but there is a relative inability to empathize with your emotional distress. Now imagine a condition, the double hit is when someone with a cognitive empathy deficit and autism also acquires an emotional empathy deficit of psychopathy. And that is an extremely small group, but a very, very potentially problematic group within the forensic system. And this is what Peter Langdon and S.E. Whiting are going to address later in the afternoon. So how does all this result in law breaking? And I'm describing two broad pathways and one variable, which it is almost an intervening variable for both pathways. So that goes without saying, the association with offending behavior, all the factors that affect everyone else is true for ASD as well. But the first broad pathway is related to mind blindness as a result of the deficits in the theory of mind. So to put it in much simpler language, it is about the misinterpretation of either social cues or rules. And so someone is relatively clueless. And when that is combined with a lack of cognitive empathy and social naivety, that results in offending behavior. So that is where you draw the dividing lines between the ardent suitor and the stalker, or the experience of someone who just doesn't understand the distress of the earlier victim when he contacts that person again. So this is offending behavior that is related to mind blindness. And the second is offending which results from a lack of central coherence. So this, as the Americans would say, is the inability to see the forest for the trees, or the inability to see wood for the trees. So people are very good at small, minute parts of what they want you to understand, but relatively inadequate in understanding the full picture. And they sometimes react with aggression when those obsessive preoccupations are interrupted. The intervening variable for both those mechanisms is sensory intolerance. And that is a case report from the British Journal of Psychiatry of a patient in Broadmoor who has this intolerance to high-pitched sounds. So from the soprano who sings to the child who cries and the dog who barks, there is an intolerance to the sound, a compulsion to escape the sound, often with aggressive acts that end up with admission to a special hospital. And this is an intervening variable for both of the previously described mechanisms. And these mechanisms are not mutually exclusive, and quite often you get a combination of all of these. Let me end with the last section, which is recognition, diagnosis, and assessment processes. And in this section, what I'm going to do is to give you a series of pointers on where to find the information. And in many cases, that information is freely available. So diagnosis, particularly in adulthood in forensic settings, is complicated by all those difficulties, of which the second bullet point is probably the most relevant. There is almost a complete lack of reliable developmental history, either because people who remember that history are no longer on the scene, or because very often when you get a patient who is in his 40s or mid-40s, if you ask a parent about their developmental history when they were 2 years and 3 years, it's quite difficult to get precise answers. I certainly don't remember it about my own children, and they're not in their 40s either. So those are complicating factors, but I'm going to show you 2 or 3 screening questionnaires and 3 or 4 diagnostic instruments. And the source for that is, first of all, the NICE guidelines for autism on the top right, and this college document, which was published about a month ago. Again, Tom Burney is the chair of the group which published it, an extremely accessible and easy to follow and short report. And the appendix lists the instruments which contribute to assessment. And the central point of that is clinical impressions, and clinical assessment is central to the diagnosis. Quite often we get into the language of, have you done this assessment, which means, have you done an instrument? And as clinicians, it is important to remember that the gold standard against which all those instruments are measured is clinical diagnosis and clinical judgment. So it is best to use instruments as an adjunct to the process of clinical diagnosis. So 2 screening instruments, the one that NICE recommends is Autism Spectrum Quotient, AQ10, freely available online. You can type into Google, you will get the whole instrument and the background literature, and it gives you an index of suspicion. The slight drawback of that instrument is if the individual has an intellectual disability, you cannot use it. The instrument which I have found clinically useful across the spectrum is one rated by staff who know the patient well. ASTASK, again, a 10-item questionnaire, freely available online. And if you, there's no cutoff score as such, but if you have 6 or 7 yeses, you have a strong index of suspicion and it warrants a fuller assessment. So those 2 are the screening instruments, and the college document mentions other 6 or 7. In terms of diagnostic instruments, apart from the clinical judgment, the 2 things that NICE recommends are ADI, Autistic Diagnostic Interview Revised, and ADOS-2. So the first one requires a developmental history, a detailed developmental history from someone who knows the patient well, and ADOS supplements that sort of structured interview with observations. The disadvantage of both is you need, it's not freely available, you need to buy it and also have specialist training. For those of you who have a background in psychiatry diagnosis and so on, the Royal College of Psychiatrists on its website has an interview guide to structure your diagnostic process, and I have found it to be a very comprehensive instrument which you can access through the college website. And for those who are members of the college, you get an additional facility. If you log in with your college membership details, you can get into that section where there are videos, a series of video vignettes of sections of that interview. So what this does is really structuring your clinical interview. What this is for able adults, i.e. those without a learning disability. And this is the 4th instrument, which came from Holland, the PDD MRS, which is useful for identification of autism in someone who has an intellectual disability. So 4 diagnostic instruments to support your clinical judgment: the ADI, the ADOS, the college interview guideline, and the PDD MRS. And at the end of that, and this is Sean Gravestock's question from before, you don't get stuck on the diagnosis alone. You really need to generate a shared formulation following perhaps the usual headings of predisposing, precipitating, and maintaining factors. And to help you structure those factors, there is something called the HELP paradigm. So health is physical health, to environmental issues or changes in the immediate environment. Lived experience refers to everything from the experience of trauma to recent life events, and psychiatric problems is the fourth component. And that psychiatric problems component can be expanded to those 10 diagnostic planes, most of which are self-explanatory. I saw a comment earlier about the number of acronyms. My apologies, but hopefully they are self-explanatory. So you want the degree and course of learning disability, autistic spectrum and other developmental disorders, mental illness and personality disorders, substance misuse, physical illnesses, psychosocial disadvantage, and then the types of challenging behavior are only the 10th plane. And quite often we spend more time on describing the types of challenging behavior than on the 9 preceding planes. So you create a formulation like that, and this will be covered in Sam's presentation later on, that the 10-point treatment program is a broad conceptualization of what things you are concentrating on. And very specifically, under the risk assessment component of that, if you're dealing with someone who has an autism spectrum disorder, you really need to make reasonable adjustments for the various items of the risk assessment tools you use, so that there is a meaningful account of the seriousness, the immediacy, the volatility, and the specific or generic nature of the risk. And this is something that those of you who are practicing could almost do with your individual patients to see how a standard risk assessment formulation is slightly varied when you talk about someone within the spectrum. So that is a quick, sorry about that. That is a quick whistle-stop tour of the assessment process. I'll end with the key messages. It was first of all to say that people with ASD are no more likely than others to break the law. There is extensive comorbid and hybrid conditions. There are 2 potential mechanisms and pathways to offending, with a 3rd factor of sensory intolerance as an intervening variable. And then we had an overview of clinical recognition screening questionnaires and interviews, and an overview of the shared formulation and some useful frameworks that will help you to craft that, including the HELP paradigm, the 10 diagnostic planes, and the 10-point treatment program. I'm very grateful for your attention. Those are my contact details, and obviously these slides will be available to you after the conference.